Welcome. We're so excited to have 340 people registered to join us today on our virtual community from the International Foundation for Integrated Care Canada, the North American Centre for Integrated Care. A warm welcome to everybody that is opening up your virtual doors and joining us on this experience as a large community across Canada, across the United States, and across the world. As you're logging in, please say hello. In order to use the chat, and we're looking forward to a very immersive, interactive experience, our best way to prototype the features of our Zoom virtual community is to say hello in the chat. If you could please say hello, your name, where you're coming from. Hello, Fiona Lynn. Welcome, welcome. Fiona's from the International Foundation for Integrated Care, our central global body that brings all of us together across the world who are interested in connecting up around integrated care and population health and well-being. And now you can see Rana, Paul, Albert, Anne. Hello, everyone. Say hello, where you're coming in from. And you can see we have such a diverse group from all over the world. And what I love when I'm saying hello to people who are joining our International Foundation for Integrated Care virtual community is that I see so many people that I know and have the great fortune to collaborate with around the world, and so many new people as well. And you can see we have students, people who are involved in research and evaluation, policymakers, funders, those that run or work in organizations in health and social care, in equal partnership from citizens, patients, clients, caregivers from around the world. And what's interesting and so critically important is every developed country around the world is focused on integrated care as the #1 opportunity for health system improvement. The level of complexity we are dealing with in order to achieve health and well-being, population health and well-being, and even move the dial on health creation requires integration. Our health and care systems are not designed to be connected, and integration is the key lever that enables this. So welcome, coast to coast from across Canada, the United States, and many different countries from around the world. The International Foundation for Integrated Care Canada, the North American Centre for Integrated Care, which is a hub of the global organization of IFIC, has been co-founded by Walter Watchus and myself. We co-founded it in 2019 because there's so much good work happening across Canada and so many efforts to connect up systems that have not designed to be connected, to reorient our focus to what is most important to citizens and their families, to patients, clients, and caregivers, and allow us to work together as one team, delivering on the promise of health and well-being. So we created a movement that helps connect us up around Canada, North America, and broader from around the world. And you can see we have people locally, we have people from New Zealand, Switzerland, really incredible, Nova Scotia, Calgary, Alberta. Really, it gives goosebumps how through a virtual community we can be so deeply connected. We can mobilize and learn together, unlearn together, grow together, and have impact together. Walter and I are especially pleased to bring today's virtual community. And Walter will introduce Carrie in a moment, Dr. Carrie Koletsky. But before we do, let's talk a little bit around IFIC Canada. Thank you. When you're using the chat, just a reminder, please press everyone and do not press to panelists and host and panelists. If your response is just go to the host and the panelists, then the rest of us, we can't build on each other. This is a highly interactive session. So please, for those of you who have not introduced yourselves yet, of the 134 people online, please continue to do so. Use the chat and be engaged. And we are both monitoring the chats, and we will each be responding within the chat as well. So a little bit, if you're not familiar with the International Foundation for Integrated Care Canada, the North American Centre for Integrated Care, it sits within the Dalai Lama School of Public Health at the University of Toronto. And we launched in actually 2018, where we took the first opportunity to bring those working on integrated care in Canada, across the States, and connect it to the global community. And we launched our first conference. Now, it was at a time during COVID and we went virtual, but I recognize many of the names on this call. We brought people together in shared purpose to look at building momentum in community, co-creating an equal partnership with clients, citizens, patients, and caregivers, and reorienting power so that those that work in health and care, or those that set policy or direct change, do not hold the power and direct how integrated care will go, but instead shifting to a focus on what is most important to citizens, patients, clients, and families, and how can we reorient what we do so that we actually deliver on the promise of what's most important to every individual, every community in Canada, each province and territory, and then beyond. And our platform is intended to help be a mobilizer that helps mobilize information, connect us up, help with knowledge translation, and really help us be in shared purpose so we can learn together, unlearn practices that no longer serve us, grow together, and have impact together. We are committed to building an inclusive network. We are open to every single person who is interested in health creation, population health, and well-being. We are a movement for change, and we want us to be accessible no matter where anyone sits on the planet. That happens at the location of IFIC Central, where I am personally fortunate to be vice chair of the board and part of the global movement. We have many members who have joined us today from the global organization and the 72 plus countries involved. And Walter and I, along with Carrie and many others, are supporting the movement in Canada and across the United States. The virtual community is free. It is accessible to anyone, no matter where they're located. And we also tape and curate the output from our experience so that it is accessible and anyone can use it afterwards. It is with that as co-founder, Walter and I offer a very warm welcome to all of you. So grateful that you can join us today. And I'd like to transition to Walter.
Indeed. Thanks so much, Jodim, and everyone for joining today. I can see we're well up over 150 people have joined already, with many more to come. And it is such an honor and pleasure to be able to host and support this work. And we have just a really excellent group of panelists to foster the conversation today amongst everyone who's attending. That's really what we're hoping to see, a lot of conversation amongst yourselves, your experience, and both challenges, but also the great rewards and benefits that you've been able to achieve by engaging and including patients, family caregivers, alongside providers, researchers, and the health system to really advance integrated care. I'm speaking to you today, and we're all from different lands, but I'm speaking from the University of Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Canada is home to many diverse First Nations, Inuit, and Métis people all across this land, and people are joining us from many of those traditional and treaty territories. I appreciate the opportunity to come together and share in our experiences together and from the lands that we speak to. And I see that some people are putting in where they are from. So appreciate that very much. And we do have international people. I've seen Spain, Switzerland, Ireland, Scotland, England, France, New Zealand, the United States, all across Canada, from Nova Scotia to Alberta to BC, many from Ontario, from the corners of Ontario, all over. So pleased that everyone is able to join us right now. We want to know right off the top if it's your first time joining us at IFIC Canada in this virtual community. So if we can post up this poll, and then everybody will have a chance to weigh in. Is it your first time joining the virtual community? That's a very simple, quick little response, and take no time at all for people to click in and let us know. Because I do know that we have a lot of people have come before, but each time we're bringing new content. And so often we're attracting new audiences. So let's see just a moment. Last few people. Okay, I think we could probably share this back out of almost everybody here. And there you have it, right? So 60% almost of people have joined us before, but we have many people who are joining us for the first time. Actually, sorry, it's the first time with 60%. So most people are actually joining us for the first time today. And that's just really, really amazing. And so we welcome you, and we hope that you'll find today's session to be really, really intriguing, interesting, energizing for your work with patient, family, and caregivers. And so just a couple quick little moments. I'd like to acknowledge people in the background here, Yenka McCauley and Tricia Martin, helping us run the technology behind here, the content and our reach out, Fiona and Neve from the International Foundation for Integrated Care, really helping to make sure and bring all that audience together. Today's entire webinar, along with the slides, will be made available at the IFIC Canada area on the the International Foundation for Integrated Care website. So you can see there, you can find all things past for IFIC Canada there. We will also cross-post this to the Health System Performance Network through the OHT Supports webinar space as well. So without further ado, I'm going to turn it over to Carrie and say, we have with us today Dr. Carrie Koleski, who I've had the pleasure of working with for some, 15, 20 years, actually. And Carrie is the Dr. Matthias Giesler Family Chair in Patient and Family Centered Care at the Institute for Better Health, Trillium Health Partners. I also have a research chair role out there, so I get to see Carrie quite a bit. And I have learned so much from Carrie over the past decades and continue to learn from her. And today she's brought together some real leaders to understand more about integrated care and patient-family engagement. What do they mean? How do they relate to each other? And have a few key examples to really learn about how does it look when it works well, and also what it looks like if it doesn't work so well. Be interested in your experiences along those lines as well. So without further ado, Carrie, I'll turn it over to you to introduce the other guests that you've brought together for today, and we'll see you on the other side.
Sounds great. Thank you so much, Walter and Jodeem. And it is such a pleasure to be here today in this beautiful community of individuals across the world to really engage in a fun discussion today, to really think about how does integrated care and engagement fit together. We know both of these things are really critical, but what do they mean when they come together, and why should they come together? And that's what we're going to discuss today. So what I'm going to do, I'm going to introduce the panel. I'm going to provide some background just for some context setting, and then we're going to move into a fireside chat panel. So I don't know if you had a look at Walter's background when his screen was on. We're going to pretend we're there. Beautiful fireplace, mountains in the background. We all have our cup of tea or coffee, and we're just chatting about integrated care and engagement. So that said, whenever you have a burning question, put it in the chat, because I really want to keep this as interactive as possible. But so pleased to present such a stellar group of individuals to help us kick off the discussion today. So we have Nakia Lifoon. Dr. Lifoon is the inaugural Health Equity Lead at the Institute for Better Health at Trillium Health Partners. She received her PhD in Social and Behavioral Health Sciences at the Dalla Lana School of Public Health at the University of Toronto. She has over 10 years of experience conducting qualitative and mixed methods research with racialized communities. And she sat on the board of directors for the Black Health Alliance, where she was the vice president from 2016 to 2018. Professor Robin Miller is an applied academic and with an international reputation in relation to integration, leadership, and implementation within health and social care. He's the joint editor-in-chief of the International Journal of Integrated Care and a senior fellow of the School for Social Care Research. He has an interest in community-led, asset-based approaches to integrated care, development of collaborative leadership in senior and practice roles, and embedding co-production within the design and delivery of transformation programs. Helen Lightfoot is a senior practice consultant with Connecting People and Community for Living Well, which is an Alberta Health Services initiative. Her background is in social work and community engagement in rural and urban settings. She was a frontline home care case manager for 20 years and subsequently held management and practice lead positions. Throughout her career, she recognized the important role community plays in supporting people's well-being, and her preferred pronouns are she, her. Sandra Holdsworth spent 30 plus years in the banking industry. She was an event coordinator at Canadian Blood Services and worked for Hospice Muskoka as their fundraising and events coordinator. Her healthcare journey includes receiving a liver transplant in the late 90s after several years of going undiagnosed with a rare liver disease and Crohn's disease. After years of treatment, she required a permanent ostomy in 2012, and she now has chronic kidney disease due to long-term immunosuppression medications. She was a volunteer with Trillium Gift of Life Network and awarded the Community Champion Award in 2015. She served as provincial director of the Canadian Transplant Association for 8 years and is currently an active patient partner with the Organ Donation Transplant Collaboration headed by Health Canada, a longtime advisor for the Muskoka and Area Ontario Health Team and formerly with Health Quality Ontario. And she's been on the Ontario Minister Patient and Family Advisory Council since 2021, and she's actively involved with the Ontario Strategy for Patient-Oriented Research, and it goes on and on and on. Such a pleasure to be here to facilitate a discussion with all of these amazing individuals and all of you here today. So going to the next slide, I'll set a little bit of context. I know I'm kind of preaching to the choir here. We're probably pretty familiar with definitions of integrated care, but just for some context setting, I really want to highlight sort of the difference between when we look at this from more of a system social science perspective versus from the patient perspective. So a definition that is used quite a bit is this first one about integrated care being a set of methods or models that focuses on funding, administration, service delivery, clinical levels, with really the goals to create connection, alignment, collaboration between more preventative aspects of care, so the cure piece, as well as the care aspects of care, so preventative and also the management of illness and social needs as well. And the goal is to really enhance the quality of life and quality of care that people receive, and also create efficiencies in the system by having people work together more in a more productive way. But most importantly, we're here today to really focus in on the patient, community, caregiver perspective, where this definition speaks from their perspective. I can plan my care with people who work together, who understand me and my care, allow me control, and bring together the services to achieve the outcomes that really matter to me. So I really, really like this definition because it really shines a spotlight on, we can be really fancy thinking about funding models and organizational factors, but at the end of the day, does it make sense to people who are using healthcare? And that's really where we're shining the spotlight. What do we mean by patient and caregiver engagement? So we talked about integrated care. Now, what do we mean about engagement? And it's really about people coming together, whether you're a patient, a family member, a friend, a neighbor, professional, an active partnership. And this could be in a clinical encounter. It could be at the organizational level where you're doing co-design work or planning something together, as well as the governance and policy-making level, and ultimately with the goal of improving health and healthcare. So pulling together our collective expertise to make things work better. Next slide. And of course, there's also different degrees of engagement. And with these different degrees, there's different levels of power. So when we talk about engagement, we're talking about power. And clearly there's some groups that historically have a lot more power in these types of interactions than others. If we think of era one, and I'd like to think we're past era one, but not always, it depends on the context and what we're focusing on, but is really about sharing information, how traditionally health systems have been set up to, I am the expert researcher, or I am the expert clinician, and I will share with you what I know, go forth and do as I say. You know, that's a very kind of, very traditional. I'm exaggerating a little. I'm sure there's still more collaboration in era one, but really it's about one-way direction. When we move into era two, you start to see a little bit more sharing powers, the acknowledgement that we all have knowledge to bring to bear, And we start to have conversations about how we can build together, work together, but there's still not quite a shared equal power balance there. And era 3, which is presumably where we would like to go, and it happens sometimes, but not always, is really where you see shared power amongst all people involved, where everyone feels valued, people can contribute to the level that they want to, and be involved and really shape the outcomes, really shape the process, and really feel like I matter, and my contribution matters, and I have a full understanding of what my contribution looks like. And so ideally, when we talk about engagement and co-design, that's what we're trying to do. And essentially, we do this to have collective impact. And what is collective impact? It's working together intentionally. It's about sharing information. It's about solving complex problems. And engagement is required for integrated care. And we can't do this alone. We can't work, as you can see in the second definition. It's not about being a single person or a single organization. We can't create massive shifts unless we work across the boundaries that we currently work in, and really think about creatively, how can we connect the dots for people so it makes sense for care teams and also makes sense for people who are using health and social care. Next slide. And I'm going to leave with this quote that I really like from Catherine Milligan and colleagues, and I've used it in several presentations because it really shines a spotlight on what we're trying to do. And essentially, we're trying to harness really strong relationships amongst many different people. Relationships are the essence of collective impact, is how they start the quote. And we're trying to build empathy and compassion, authentic connections between diverse participants. And these deep connections create innovation. It creates new ideas. It also takes time. Some people say, well, it's going to take too long to build these relationships and then do the work we need to do. But it's so critical that we really appreciate all the different types of knowledge each of us brings to bear. Single-handedly and as an individual person, we don't have all the answers. We have to really collectively look at that together. And this quote really kind of gets at sort of a similar sentiment, is that we need to really work together to move past these kind of like rational frameworks of just plug and play of creating change to a more authentic, consciousness altering way of working together and learning together so we can significantly change. So it's about kind of shifting the systems we work in and shifting our approaches and our methods of working as individuals. I lied, I had 2 quotes. So the final poll before we engage in discussion is, how knowledgeable are you about patient and caregiver engagement within integrated care? I provided some info you may have already known. Maybe it's new, I don't know, but fill out this poll. And then we're going to revisit this after we have our panel discussion, and then talk a little bit more about where we go from there. So you see 10 is very knowledgeable, 1 is not knowledgeable at all, 6 is somewhat, and we're really in a space where we can learn together and maybe move the dial on this. Okay. So depending on, I can't see how many people responded. Are we able to show the poll on the screen? Yes. Okay. So we have, okay. So we're all on a learning journey together. I am also on this journey of figuring out, what does all of this mean? How does it fit together? We have people kind of falling generally in the middle. So lots of opportunities to continue to learn together. We're always going to be on that journey. So this is actually a really great result to see, is that we have some familiarity, but we're really, building on that knowledge. You've come to the right place. Okay, so we're going to close that panel. And now we're going to kick it off to the fun kind of conversational part of today. Hope everyone has their cup of coffee or tea or whatever it is. And we could really just discuss, what does this all mean anyway? And what are some examples we can share? And again, please put your questions in the chat and share with everyone. As Jodine said, we could really start to build on all of our ideas together. And so how this will work is I have sort of a set question or 2 for each panelist, and then I'm going to shift it over to looking at the chat and then having all of you generate, your ideas, and we can shape the conversation based on the things you really want to dig into. So think about, what are your burning questions, and start to put that into the chat. So to kick things off, Robin, I'm going to start with you. And I I wonder, in the work you've done and the ideas you've generated over all the years of work that you've done, in your view, how does patient, community, caregiver engagement and integrated care fit together? And can you sort of speak to some examples tangibly so we can understand what that means from your perspective?
Yeah, thanks, Kerry. Very happy to go first. So what I thought I'd do is reflect on a project that we've just completed over the past 12 months as part of a centre called Improving Adult Care Together Centre, which is a UK-wide centre, which is not about generating more research, but trying to understand how we can use evidence in order to inform the delivery and planning of social care in collaboration with healthcare. And in the centre, we have a broad view of evidence. So yes, we do try to look at research studies that have been done, but we also looked at lived experience and also practice wisdom, because we see those as being equal contributions as evidence. And the first project that we did was in Mid and East Antrim, which people may know is in Northern Ireland, just outside of Belfast. And it's a rural area, a number of small towns. And the reason we went there was they had a long-standing project there run by Mid and East Antrim Age Well Partnership, which I think is a great example of community-based integrated care in action. And what the project does is it connects together social workers, general practitioners, and pharmacists with community resources. And MIAP's project workers bring together locality hubs of those three professionals. They then will respond to older people who are seen to be isolated and generally struggling with life, and go and see them and have a very open conversation about what matters to that older person and their family. And then we'll connect up the older person and their family with a range of community resources. And what's different about this project rather than traditional social prescribing is, first of all, it very much emphasises the interprofessional aspect, that the locality hubs an opportunity for those different disciplines to come together to talk about the needs of individual older people, but also the community. The second thing is that it takes a real community development approach. So it works with the different community-led organisations to talk about what they see as the emerging needs of older people, and to make sure that they've got the capacity in order to respond to those. And the third thing is that they make sure that where community-led organisations support older people, that they receive funding for that, so they don't become overwhelmed and are unable to respond to the community need. And the reason why that project, I think, is so successful and based on such an integrated and person-centred model is because the organisation itself is based on the needs of older people. And it was set up in 2011. And over the last 12 years, it's connected or developed a series of older people's groups in the locality. And I think currently it's engaging with 50 older people's groups on a regular basis. And older people are involved throughout the whole organisation. So they're involved on the board, they're involved in the development of projects, they're involved in the evaluation activities, and they're involved in the delivery as well. And that means the organisation has evolved in response to what's important to older people. So along with this social prescribing project, it also has a whole range of other activities, which include a befriending service, which include activity groups, which includes mentoring and support for people. So that's because it's based with older people, involves older people, it can therefore respond to the needs that older people think are important. And the final reason I think it's really important, it's a great example, because of the credibility that MIAP has with older people, and because the credibility has with these different professional groups, it can bring them together for meaningful discussions. And at the start and the end of our demonstrator project, we had one of the best world cafes, or two of the best world cafes that I've ever been part of, where we had older people, we had professionals, we had policymakers come together to talk about the importance of asset-based working and to look for opportunities to make it better in Mid and East Antrim and Northern Ireland as a whole. And there's lots more I can share, but I'll probably stop there because that's my 2 minutes done, I would think, Kerry.
Thank you so much, Robin, for that. There was so much in what you said, and a key nugget that stood out for me when you kicked off your example is you talked about the importance of the lived experience knowledge and wisdom, as well as the practice-based wisdom in trying to move any dial, in our system, and also providing a lot of power to the community, I heard, and really learning from individuals themselves what is it that they need, and creating spaces for people to dialogue and to build together. So I saw a clear example of integration with the health and social services, community power, and also harnessing the knowledge of so many people. And I guess when we go to Belfast for the next integrated care conference, perhaps we can go check out this model. That's what I was thinking. Put a little plug in for the conference. But Helen, I'm going to look over to you now to answer a similar question, is how do you see these things coming together, being integrated care and engagement? And can you provide an example based on the work that you're doing?
Sure. Just wanted to say thank you for inviting me to be part of the panel. It's great to be here, part of the conversation. Yeah, so just for a little context around the work that we've been doing with rural Alberta communities, is that we've brought together folks from the health sector, so doctors' offices, home care, those kind of folks, as well as social services, and then some community partners too. So people like maybe from the libraries, from the churches, community organizations, as well as our work focused on people living with dementia. So folks living with dementia and their carers, and brought them together in what we're calling collaboratives to look at what exists within their community to support well-being. And that's been really key for us to move away from a medical kind of model approach to it, but to be asking questions about well-being and what supports theirs. And we're looking at supporting those individuals, but also that team that's coming together also. So what's the collective well-being? What is needed there for them to be able to sustain their work? And the key role for the individuals, so people living with dementia and carers, has been that they have really set the priorities within this work. Some of that was done through research that we did, but also on every time those collaboratives meet. And we worked with 5 rural communities in the last 3 years around that. And so they're setting the priorities. They're involved as much as they're able to be in terms of, implementing activities and that kind of thing with it. And I think part of what's come out of that is a really great understanding of what is important to those folks. I heard what you were saying before, Carrie, in terms of relationships are seen as taking a long time, and absolutely it takes time to build those. But what we found is that once the relationships are built, then the work just goes crazy, and it's very creative, and it produces way more than we ever expected. We were hoping, our initiative started during the pandemic, and we were hoping for 1 activity per community would get implemented, and it turned out to be 60 activities overall across those 5 communities. And that included things like arts programs, exercise programs, education events, a lot of support programs, memory cafes, those kinds of things. So it's incredible what can happen when people come together. I think the other kind of unique thing that we've been learning about within there, and it's one of the big things within the healthcare system, is around navigation. And what we really heard from these teams was that there's kind of a hub and spoke model that they're using. There's a core group of people, and then they have connections within their community. And anytime an individual touches any one of those communities in the hub and a person within the hub and spoke, then that person becomes responsible for that navigation through the system to where that person needs to really get lined up. And I think, it's relationship based, and I think it's really powerful, and I think it's really key for this work to move forward with it. So I think I'll stop there also and let you pass it on to the next panelist.
Thank you so much, Helen. And it's so wonderful, to hear, just how much impact you can have by taking the time to build those relationships, because we often hear you have to go slow to go fast. And you ended up creating such big impact after creating those connections, engaging with people who have dementia, their families, other members of the community, and also focusing on local assets. And I heard that from Robin as well, like what's currently working well that can be leveraged. We don't always have to create new. So I love that asset-based approach and really looking to the community for the answers. So thank you for that. We're going to switch gears a bit, and I'm looking over at you, Sandra, and I know you're someone who you've been involved in the health system as a patient for many years. You've been involved in the health system in terms of co-design and building things with various types of individuals, be it providers, researchers, managers in the health system. I just want to go back to what does integrated care even mean? From your perspective, you're someone who's been involved in different ways in the health system. How do you define integrated care? And the follow-up I'll ask you after is, why bother engaging with patients, families, and caregivers in integrated care? So we'll start with the integrated care one. What does it mean to you?
Okay, thanks, Carrie. Also, I wanted to acknowledge that although I work with a lot of groups, I'm here today representing the Patient Advisors Network, a national organization of patient advisors. And what does integrated care mean to me? Well, if I was to give a definition, I would say coordinated, effective, and efficient care with empathy and compassion that reflects a holistic approach to a person's health needs from prevention to end of life, focusing on physical, mental, and social health. So myself, as a patient with multiple morbidities and an active user of our healthcare system for the majority of my life, integrated care is necessary. My safety, treatment options, and outcomes rely on integrated care. I still today need to repeat my history each time I see a new care provider. Have had delays in receiving diagnosis. For example, it took 10 years for me to find out I had a liver disease and Crohn's. And many times I was told that it was in my head or it was my diet, which gaslighting is another thing that happens to patients, unfortunately. I've been required to duplicate tests, which is a cost of our system. And I've had issues with errors with medications because of lack of integrated care. I also need to use multiple patient portals to access my health records, and in some cases are required to pay for them. I hope that someday I could have a case manager or navigator to help manage my care. I feel that I've gained a master's in navigating our healthcare system. And to be honest with you, looking after my healthcare is a full-time job. That would be my reply, Carrie. And did we lose Carrie? I think we did. Oh boy. I scared her. I think I'll go on and answer her next question for her. What she wanted to know is why is it important to engage patient caregivers and community when designing and implemented integrated care? So one of the things that I wanted to point out, first of all, of course, we want to have patients and caregivers and community involved, but I also want to acknowledge that engagement around primary care and health sectors has been a challenge. And so how is it like, because of the way our system is fragmented, everyone sort of does their little part of the job. They see one part of the system and they don't see everything. So I want to acknowledge that. But I also want to go back now and refer to the slide that showed the different degrees of engagement and powers. Let me just catch my thoughts here for a second. So the first item should move, in my opinion, from inform to empower. So when we're talking about our communications with primary care, so we're in the doctor's office, we've gone from, I'm pretty sure, like not everyone unfortunately has, but I'm pretty sure I give credit to our primary care doctors that we have gone from an inform, but we need to go to an empowered. And I'll address that later on. So for my comment on that is that we need to work towards changing the provider-patient differential by having providers see their patients as partners through their patients as partners through shared decision making. Patients need to feel empowered to be active participants in their healthcare plan and to express what matters most to them. I think, Robin, you mentioned that. And also, too, patients should be acknowledged for the knowledge that they have gained by their lived experience. Of course, our doctors have a lot of knowledge, but living with an illness and navigating the healthcare system as a whole, as I said before, you get a master's in that. Going to the next section, which was engaging patients and their family. This type of engagement gives the opportunity for providers to receive feedback directly from a diverse group of patients and caregivers on their experience and suggestions to help with improving patient experience and processes. It's a great way to help evaluate performance. And then the last part on codifying and co-design. Co-design is something that, to me, is where the magic happens, where providers, patient, caregivers, and community collaborate to define and co-design the best healthcare system. We need to find another word for this, meaning the healthcare system. I don't like calling it a system. Maybe that's the problem. That advances meaningful change. Thank you. And I will pass it over to Walter. Thank you, Walter.
Thanks very much. And hopefully we'll have Carrie back here soon to help guide us. But in the meantime, I want to have the opportunity to bring Nikia into this conversation. And Nikia, you've done a lot of work in the space of health equity. And we're really interested in knowing, if you have some thoughts around how we can better consider or best consider equity, diversity, and inclusion in our efforts to engage the patient's family for integrated care.
Thanks, Walter. That's a great question. So whenever I think about a question like that, I first kind of stop and say to myself, and say to myself / the folks that I'm chatting with, is essentially, how are you defining equity, right? Because equity in North America is going to look different than equity in, for example, Ireland, in the Caribbean, and so on and so forth. So how we're defining equity in the context of where we work is beyond importance to start that journey to better engage for integrated care. Same thing with diversity, same thing with inclusion. Those are going to look different in different contexts. And when we're having that conversation, oftentimes what can happen is, because equity, diversity, inclusion has gained momentum and interest and focus in recent years, is it comes into play, those conversations are had, but then the work is done without actually stopping and critically reflecting on what those things mean. So as I said, we should first start off with what are those definitions look like in the context and the spaces that we're working in? And then how are we actually moving towards incorporating that into integrated care? Because again, traditionally, kind of similar to the slide that Carrie mentioned, the usual kind of way of doing things is, you find a problem, whether it be through data that's being collected within your institution, organization, you identify that as something that needs to be addressed, and then you potentially move towards the literature, look for solutions there. And then maybe after doing all those things, then you say, oh, you know what, it's time for us to engage with community patients and caregivers here. And I'm sure I'm preaching to the choir here, but that's not the way that we should be doing things, right? So what we should be doing is we should be actively engaging and having conversations with caregivers, patients, and community members from the very beginning. We don't wait until we're at the end of things and we found problems to then say, oh, this is a time when we should be chatting with folks to see how they can help us. We work for patients, we work for community, we work for caregivers. It's not the other way around. And when we start from a place of being the holders of knowledge rather than individuals that are looking to gain better understandings as to how to support and enhance the health and well-being of others, then we essentially are working from a point of disadvantage for the folks that we're supposed to be supporting. So starting the journey, working with patients, working with caregivers and communities is where we should, begin our journeys together. And in doing so, that would lead, in an ideal world, I say that, again, preaching to the choir here, in an ideal world, that's where we should be starting. And once we do that, then we can actually then say, we have some ideas of what diversity, equity, inclusion are, but what are your thoughts on those ideas? And then how can we work together to be better with co-design? How can we work better to make sure that what we're thinking of doing aligns with what is actually happening in the context of how you are, navigating the system? As Sandra said, she's probably got not a master's, but she's got a PhD, I'm sure, in, healthcare right now. And you shouldn't have to do that. You shouldn't have to be actively involved in that way, in that depth, to take care of yourself. That should be something that's taken off the plate so that you can actually, be better health-wise, and your health outcomes can be involved and enhanced. So how do we make sure that we're taking those things off the plates of folks? And how do we make sure that we streamline care in a way that responds to patients, caregivers, and communities' needs, that is actually, equitable, that actually reflects a diversity of needs and and places and spaces that our people are coming from, and how do we make sure that we can be as inclusive as possible so that folks get the needs that they have, you know, addressed and cared for when they need it the most. And I think I might have gone over 2 minutes, but feel
I
free to
think
let
that's
me know.
been really, really great. Happy to hear you. And I hear and I can see that Carrie's joined us again. And that was just Carrie, Nikia talking about how we can consider equity, diversity, and inclusion in our efforts to better engage for integrated care. And I'll leave this back into your trusted hands.
Thank you so much. And so what happens sometimes in our system is we're well on our way, we're working together, having a great conversation, and then suddenly someone disappears. And it could feel a little bit unstabling as what it has. So this was all planned for sure. I was supposed to disappear from the call. What happened was my internet dropped on my computer and I'm joining from my phone. And so in the spirit of integration and co-design, it's about being adaptable. So here I am. I found my way back, and my amazing team that I get to work with was able to carry on the conversation, and Walter was able to jump in and continue on. And really that's the spirit of working together, is when things happen that are unexpected, we sort of pick up and we continue to move along together. And I thank everyone for answering those key questions to really get us kind of kicked off for today. But now what I'd like to do is move it over into the chat. And because I'm on my phone, it's harder to see the chat. So I'm going to ask Yinka and Trisha to have a look through. I know there's been a lot of things coming through, and we're going to start to answer some of your questions that you have based on what you've been hearing so far, and just some of the burning questions that you have in general around integrated care and engagement. So Yinka, I'm going to look to you to see what's coming up in the chat.
So we have a question from Deborah, which is, has integrated care improved the health outcomes of those that are marginalized or homeless? And a second question in relation to, have we made any progress in making palliative care available to those marginalized or homeless?
Thank you. So I invite anyone on the panel now to respond to this question. And great question. Thank you for that.
Yeah, no, that's a great question. And obviously, in many ways, the proof of the pudding to all this energy we put into integrated care. And the research evidence on integrated care is very complex, as you can imagine, with a high degree of local context influencing what outcomes that are achieved. But there's two things I would say. So in terms of kind of vulnerable groups, in particular those with more complex needs, such as homeless people, etc., you know, we can clearly see improvements in health outcomes, people's experience of accessing care if it's better joined up and coordinated. Issues such as, do people access hospitals less, is always tricky because there's so many other factors that influence it. But I think on the whole, we can generally see some positive impacts from better integrated care. And we also must remember that if we don't integrate care, what we have is fragmented care. And there's numerous research studies which highlight that if we don't join up, we don't communicate, we don't coordinate, we don't put people at the centre, what they receive is poor care, and care that will not be focused on their needs, and perhaps indeed may overlook those needs. So I think we can definitely say that integrated care is able to make a real difference to those vulnerable populations if it's well planned and it has people at the heart of them.
Hi,
Go
Carrie.
ahead.
Sorry, yeah, I just wanted to add to that in our work, what we also found is by, you know, increasing that awareness and connection at that community level, then those are the folks who actually know those marginalized populations. And so then that you have to get really creative about how those voices come to the table, but it is possible to do. And it is really through building those relationships. And then you start to adapt things. And one of the things that we found really was that those folks who were marginalized and homeless was one of the ones that came up in our work. Really, it's around where they are. They have a community where they are. So sometimes our solutions pull them away from the supports that they have. And so we need to look at how do we do things right where they are with the people that are around them.
Can I add, Carrie?
Yes, please, Sandra, please go ahead.
Yeah, it's ironic. In my spare time, I volunteer for Gravenhurst Against Poverty, and I attended our Alliance Council meeting. And so it's a community coming together. And it was really interesting to hear people from Canadian Mental Health, the OPP, the Public Health Unit, Salvation Army, Canadian Blood Services. And so we talk a lot about the effects of social determinants of health. And so one of the things that, I've addressed with the PFACT, the minister's PFACT, is how can we have our, so just in general, sorry, I realize we're international here. How can we get our healthcare systems also working with our public health systems? And how can we share that information? Because like here in Gravenhurst, we have our family health team, and then at the back, they have the district community public health service, but it's referred to as a welfare office. Well, it does so much, there's no such thing as welfare as Ontario Works, but there's so many resources that are there. So if we can get those two sectors working together, and this is the whole point of collaboration, so that's how I think we can help that.
Thank you, Sandra, and really great example. And I want to highlight as well, and it's come up a couple of times, Helen, how you talk about when you can reach out into the community, they could reach further and find individuals, who we want to connect with. And Sandra, in your experience, you're seeing like what organizations are critical in terms of what needs to come together for people. Because often we talk about we need to diversify the people we work with, but one relationship then builds into another relationship, which builds into another relationship. And I really wanted to highlight that because personally, that has helped me in my engagement work as well with my teams. So I'm going to bring it back to you folks, all the participants today. And Yinka, any other burning questions that are coming up in the chat? I see it's brimming with comments and resources and questions. So let's go to the next one that you see.
Lots of great questions and comments. A question from Liz Denier, wondering how we effectively move the bar through the stages of engagement you mentioned. How do we get from level 2 to level 3 to really equally integrate patients into the process and continue to break down the power differential?
Such a great question. So you'll recall the slides, how we had different degrees of power sharing and different degrees of engagement. So we're talking about moving to that third really evolved phase of engagement. Does anyone want to take that on? How do we get there? So it's not a one-off, but more of an ongoing form of engagement.
I'll start the conversation, Carrie. So first of all, we need for health, those who are wanting to start to co-sign, to realize what lived experience is an asset. And as I said, it's where the magic happens. And I think, when Helen said, they thought maybe 1 or 2 projects, but once you start inviting the families, patients and caregivers and community, the conversation starts and you see how it works. And I see this a lot in research, but you have to try it. And until you try it, you don't know it. But it has to start at our government levels as an expectation and at our leadership. And, Carrie in Ontario has done some excellent training on it, but it's something, it's something that you have to learn. But also I wanted to appreciate, though, that, engagement and partnership is over and above everything else of what people are doing. But once you do it, I think it's going to reduce the amount of workload that is being put on our healthcare providers and our sectors.
Thank you, Sandra. Go ahead, Robin. Yeah.
Oh, well, I was going to bring in Helen, but that's fine. So, thanks, Sandra. That's very, very, very helpful. And Anne Wojtak and I at University of Toronto just finished a project looking at co-production integrated care. I mean, we talked to 25 people in 12 different countries who've been seen to make an influence. And one thing was quite surprising was some of the basics of co-production that we don't often do. Those issues about communicating with people, making sure we put venues that are accessible, that we make sure we correspond in a timely way, that we treat people with respect, that we have continuity of individuals working with them. Some of those practicalities, which we know make a difference, but we don't necessarily embed in what we do, are so crucial. And there is something about being involved for the long term. I think there's a terrible history in integrated care. We start off doing a new program, and so we think, yes, we must communicate with the community, we go out and speak to people. And then as we get in the busyness and challenge of implementation, we then get distracted from that. and we let people drift away and we don't involve them. And that both removes the opportunity for them to shape and improve the program, but it also makes people very cynical and skeptical about how honest and how authentic that engagement was. So there's a real need to cover the practicalities and to engage with people in the long term, because when we get to know people over a longer time period, we get to trust each other, we get to respect each other, we can say difficult things, which is what we need to get to in co-production, because we're not always going to see the world in the same way, but that only happens if we do it over a long-term period, so we can develop that trust.
Just wanted to build on what you were saying there, Robin, and talk about that. I think that there's a specific role for helping shepherd that along. In our project, it's us as what we call our provincial team, but there has to be support there for the individuals as well as for the teams who are working on this, and then information to go up to our decision makers. So there's an in-between role there that I think is not always present in some of the work that we see, and then it creates that some lack of continuity in information sharing.
Sorry, just to add on a little bit more to what's already been said. I definitely agree, Sandra, Robin, Helen, lived experience is an expertise and it should be treated as such, and it should be compensated fairly. So what can happen oftentimes is, again, folks will come into different community spaces and say, we'd love to hear from you, we'd love to hear your feedback, and then they don't get compensated for their time. So whether it be financial contributions, whether it be, childcare, et cetera, just like Robin said, there are so many little tiny details that oftentimes get lost in translation when we're trying to actively engage communities, caregivers and patients, that those little things are the things that folks will remember. And then they'll take that up and say, I might not actually want to actively participate in the next round of conversations. And I, myself, Carrie, Walter, we also work from the learning health systems perspective, where, the idea is that the research informs practice and practice informs research. And in, the conversations that we've had recently about the learning health systems is really centering the patient, caregiver, and community as the key cornerstone and part that moves the conversation around advancing health systems and care as alongside equity. So if we don't have those two core components in the health system and systems, we can't actually move things along. So if we don't make sure that those portions of the system are working, and we're not actively engaging and making sure that we're linking folks to the care that they need, and also making sure that we're having conversations that are consistent, so folks see the continuity and see our interest and see their feedback and perspective taken up and actually used to inform practice and care, then the whole system goes to hell in a handbasket. Pardon my French, but yes.
Thank you, Nikki. I always look for sound bites. I like that one. Speaking of sound bites, Sandra, I just have to quickly highlight something you said. You said lived experience is an asset, and it's where the magic happens. And I just said, yes, as soon as I was thinking, that's exactly why, we need to value the knowledge and expertise of patients, families, and communities. It's such an essential piece of what we do. And Robin and Helen and Nikia, thank you for reminding us of the fundamentals: accessibility, showing value in different ways, and really being thoughtful about how we're creating to connect with individuals. So those are a few things that stood out from that response. I'm going to flip it now back to the chat, because I know there's lots more questions coming in. So Yinka, anything that you wanted to pull out of that to keep our conversation moving?
Definitely. Great segue. We have a question from Laura Collins. How do you prove that investment in patient voice and engagement is worthwhile? How do you convince senior leaders that in times of austerity, this spend is crucial?
Who wants to take on that one?
Well, I'll start. I'm sure there's more to add to it. I think it's really important that we show impact in lots of different ways. I think the stories from the people who are involved, and then the stories from the people who are impacted are key ways of being able to say, within the communities we worked with, there were no supports when we started this work, and now there are supports. So that's a dramatic change. But we also looked at things like the impact of the healthcare system, but also a social return on investment to show the impact to all of the publicly funded systems, which equaled the impact to people living with dementia and care. So we feel like that's a huge win for that. But then there's things around, counting some of the numbers, because people do like to hear numbers, as well as, doing formal evaluations. So I think we have to look at lots of different ways to bring that information together.
Thank you.
You can
Others want to
add-
add?
Yeah, because that's what I wanted to say. I put in the chat, like, sorry, that's my Alexis reminding me if I ate lunch. Health devices. No, so what I was going to say, it's important to measure impact, right? So I'm working on a project and a research on using the performance measurement engagement tool that came out of the Center for Excellent Patient Partner, CEPPP. It's out of Quebec. And, because we have to measure, and it's difficult to measure. And as I said, like, until you do it. But so, when we start looking at, like, we look at performance measurements, and we look at, time people wait to, see an ER, time people get a doctor. But we also need to measure how our organizations are doing in patient engagement. What involvement does the community have? What voices does the patient have, and stuff like that? And we also have to remember too, unfortunately, our healthcare system was not built for the end users, right? And it's not until, like, you step out of the system and you start looking at it as a whole that you realize that. And so bringing patients, families, and the community to the table, we can restructure. You step out of this like that. And so bringing patients. That's funny. Anyway, yeah, I'm not sure what happened there. Oh, I guess Carrie came back on. Okay, so yeah, it's not like, so anyway, my point, you threw me off, that's okay. But we basically need to look at developing it for, working together in co-design to build it so that it's working both for the end users and the providers. Right now, it's more centric on the providers.
Thank you, Sandra. I found my way back. I had a journey from the webinar to my phone back on, and yeah. And thank you for your response. Did anyone else want to add on to Sandra?
Sure. I just wanted to quickly add on to Sandra. Oftentimes we measure performance and whether, healthcare is doing well by numbers. However, coming from a qualitative mixed method approach in my world, I often say that numbers without context are just a bunch of numbers, right? And if we're going back to, the big wigs of various institutions, folks like stories. They like to have some kind of context put into the numbers. So if you say 55% of healthcare users had great outcomes, that's wonderful, depending on where you are. Again, just a general example. However, you say 55% of users had great outcomes, and here's a story about so-and-so who came from such and such and whatnot. And if we highlight that story, if we provide context, if we talk a bit about the social determinants of health and how, a particular program or organization helped that individual to get a better health outcome, then oftentimes what'll happen is that quote unquote big wig will say, oh, okay, well, that's interesting. I didn't realize that those numbers actually were, there was a person behind those numbers, and these are the positive outcomes, and this is the impact that had not on that person, not just on that person, but oftentimes, when folks are coming from various communities, racialized, underrepresented groups and whatnot, they're taking the learnings that they've gained from their engagement in various healthcare systems, and they're sharing that with their loved ones. They're sharing that with their peers. So you're not just helping that individual, you're also providing, opportunities for learning and potential additional engagement from folks who may not have access to a particular system or program because of a number of issues that they may have experienced in the past trying to access those various services. So definitely again, like I said, data without context are just a bunch of numbers, but from that context, you also have an opportunity to impact other people in a way that you may not have anticipated.
Thanks. Just to add to what Naki said, what was excellent, and the others too. I mean, I think it's demoralizing, isn't it, a little bit, that we still have to convince people that involving individuals and families in their own care is a fundamental part of a quality health and social care system. But and I do think also, I mean, I know generally with integrated care, we're for kind of locally developed solutions that emerge from good practice. But I do think sometimes there's a role for government to actually just say this is not good enough. And it should be part of your regulatory system that you look at whether or not people in communities are involved in designing and delivery of health and social care systems. But beyond that, if we do have to convince the senior decision makers, one thing we need to be aware of is what's important to them. What is it on their desk that's actually giving them sleepless nights? And often that's to do with over demand on particular services and worries about budgets running out of control, etc. And if we can demonstrate that involving people and families in those services and those pinch points will make a real difference. And one of the things we looked at in the Mid and East Antrim project was we noticed that often when people thought about social prescribing and involving community activities, they thought about people with kind of low level need who had kind of longer term isolation issues, which are all very important, but they never really thought about acute crisis issues. And one of the things that they really struggle with in Northern Ireland is enabling people to leave hospital in a timely manner. And that then leads to people spending longer than they have to in acute care settings, but it also means that other people can't be admitted. So one of the things we looked at in the project was, well, could social prescribing have a role in terms of enabling older people to leave hospital in a timely manner? And whilst it was only a 12-month project, the emerging evidence we had was definitely, because actually lots of the issues that prevent people going home and staying at home are to do with social networks and isolation, and some of those practicalities of having food in the house and having some of those basic repairs done. So I think the point is to look at what are the pressure points for those decision makers and evidence how involving people will help them with those pressures that they have on their day-to-day work.
Thank you so much, Robin. Helen.
Yeah, I just wanted to add to it a thought that came to my mind also that we found in our work is that it really impacts workforce. And I think this is a global issue also, right? That there's getting to be fewer numbers. But what we found with these community teams is that they loved the creativity that they had, that they were actually able to see things be created and be rolled out within their communities. And so I think great satisfaction for that workforce part of it to keep, that retention kind of area with it. So I think that's another selling feature for our leaders.
Thank you for that. And I think about this concept of like windows of opportunity and sometimes strategic framing in terms of what we want to get done, with our communities and for our communities, but looking at that broader climate, which, and the context of the organizations that we might be situated in with very clear directions or pressures or imperatives, and how to kind of find that sweet spot where we can come together. And so that's what I'm taking from this dialogue. And I think it's strategy and engaging communities for integrated care is critical, just so we're not kind of spinning our wheels and engaging and then things aren't going anywhere. Where's the receptor in the system that we could link it to see that change? And so that really sparked excitement for me in hearing that dialogue. Does anyone else want to add, or should we flip it back to the Sandra, and then we'll go back to the audience?
Yeah, quickly, because I originally wrote this down. So, when you look at integrated care, and let's look at like a family health team, or in the bigger cities, they'll have like a primary care network or community health hub. There's a lot of pressure on our primary care doctors, and there's a lot of administrative burden on there. And I don't blame them. We were looking at something about the amount of time, it was on LinkedIn, people were saying like how much a doctor got based on their clients. But, they was run like a business, a lot of them, about like their staff and everything. But, there's also this things that we refer to as PJ time, when the notes are done, and I have specialists, and I get emails like, midnight and 2 o'clock in the morning, 5 o'clock in the morning. So to me, it's like, as a patient, I visualize an integrated care place where I can walk in, and as a patient, I can choose before I get there how I want to receive care. Do I want to go in? Do I want to get a virtual appointment? But I also want to be able to go in and say, well, do I need to see the doctor today? Or could I see a nurse? Could I see the social worker? Can I just go see the OT? And like, you know, unfortunately, the way our systems are built here, like at Ontario, and I can't speak for across Canada or internationally, but the doctors are sort of almost like a gatekeeper. They have to see every single patient just for them to see like a social worker or something like that. So to me, that would be the best way to get integrated care, where there's a one-stop. And that would also include, that's what I said in my opening statement, where it's physical, mental, and social, and that you can get it. And as I was talking to the people this morning, I said, you know, you should have information available when I'm going to see my primary care doctor, that I know that there's other resources there. But I also think that because, unfortunately, I heard a stat that only 85% of Canadians are receiving healthcare, and that's not right. So the other thing is, what I really strongly believe about community is we have to go where the people are. So does that mean that we go to the person that was talking about the Alzheimer's? I think that was you, Helen. You know, my mom goes to the Alzheimer's Day program. Why can't a primary care doctor go there and see 20 patients at the same time? Go to have a health hub at the university, you know, go where people are. So some idea.
Thank you, Sandra. And your example reminds us that the answers, you know, sit with patients, caregivers, and communities in terms of how we could think about systems and how we set them up in a very different way. And you also identified what brings you most value. What do you need? What type of provider would be most helpful based on the needs you have, the concerns you have? So there's an element of choice, is what I heard and what you were talking about. So thank you for sharing that, because it brings us back to, why are we doing this, and why is the engagement so powerful with patients, families, and communities? Is because they're the ones using the entire fragmented system, essentially, right? So they can help point.
Oh, it looks like Carrie's got kicked off again there.
Indeed, indeed.
You go ahead.
Oh, that's okay. But I'm gonna take some prerogatives. Jodine, yeah, feel free to jump in with any questions of your own. I'm looking ahead, and I've been listening to this conversation, and I think there were some questions in the chat around some of the supports to enable and engage patient family caregivers in work. And we in IFIC Canada, our next event webinar like this, we want to be talking a little bit about some of the policy supports for integrated care. And I'm going to push at that event around the policy supports for patient family engagement in integrated care based on this conversation for sure. But maybe as a little bit of a prelude to that, I might hear from you if there are essential roles, or maybe this can totally happen absent of any policy or support or initiative around that. But maybe there are some key pieces. I'll take the prerogative of, I'll go to Nakia, then Helen, then Sandra, and then Robin around this. If you don't all have to comment, but that would be it.
Well, that's a good question, Walter. Always with the good questions. So I would say, you know, if we're talking about policy in terms of, you know, integrated care and caregiver, patient, and community, you know, engagement, definitely more conversations, or more, I don't want to say requirements, but more encouragement of you know, higher levels of institutions and folks really incorporating, you know, incorporating community, patient, and caregiver into conversations around policies at their institution. So I think folks, I was skimming through some of the chat, and folks were saying, you know, how can we be better at involving folks at the table if we have this involvement on the side of our table, right? And we don't actually have the opportunity to really actively, you know, reach out to and engage with folks. So I say, you know, there should be more policies around you know, dedicating X amount of time to making sure that folks have the time to actually do this in a way that's effective, that's consistent, and is sustainable. So I think Robin mentioned, you know, earlier, oftentimes that happens where you start the journey, then things happen, people fall off, and so on and so forth. We need to push for policies that make this type of engagement sustainable, and that, again, folks feel that they're seeing, not just feel that their perspectives and feedback are taken up, but they actually see that taken and used to impact care, and done in a way that is ongoing and not just a one-off. Because, you know, we get those funding pots, it's a one-off opportunity, and then we, unfortunately, depending on how things go, have to move on to the next round. So how do we make sure that folks, their feedback is taken up and actually done in a way that's consistent? And again, when we talk about different organizations and different folks, you know, we need to make sure that everybody gets a chance to speak their mind, and make sure that that is a part of the conversation.
Great, thanks a lot, Nakia. So,
Thanks.
Helen, and you know, maybe you might touch on the sustainability of things too, just to make it more complicated.
Yeah, yeah. Well, I think I wanted to just pull back in something that we talked about earlier in our conference here, and just that, you know, people need to be involved from the very beginning. I don't know how many times I've been involved with things where it's like, okay, we've got our goals set, we've got our committee set up. Now let's recruit some caregivers and people, you know, individuals onto that. And it's like, that's way too late. You're in the wrong spot. And I think that is part of the sustainability part of it too, because if people are involved from the beginning, you will head in a direction that is able to be built that way. The second, and I think very much related point to that, is I think one of the things that I see all the time is that we're very much a referral-based system, and that's around power and gatekeeping and those kinds of things. So if we can move away from that and make it a partnership, so we're talking about what's needed, everybody's at the table. In a lot of ways, I don't think it's, I think it's changing what already happens within the system, but doing it in a different way. So it's not more money, it doesn't need to be sustained, but the power needs to move, and power, that doesn't often cost money to be able to move that power. So I think if we embed it right from the beginning, then we'll have the sustainability.
Great, thanks. Maybe Sandra, just one or two sentences, and then on to Robin, and then we'll let Jodine come back. And Carrie is coming back. She's working at it.
Yeah.
From a different phone this time.
Well, I don't have a problem saying that I think it needs to be regulated, and that patient engagement needs to be a something that is required in research and in healthcare. You know, I think in research, which I do a lot of work with, is, you know, it's got to be on the grant, but it's got to be the whole thing, and in healthcare as well. And until we start making it a priority, I'm sorry, it feels like lip service to patient partners and stuff. And I'm going to use a quote from Julie Drury, who was past chair of the Ministers' PFAC in Ontario. And this goes to what you're saying, Helen, is that we as patient, family, and caregivers and communities, we want to be there when the mix is being bought to build the cake and it's being put together, not when it's coming out of the oven and then we're just the frosting on top of it. If we could work towards that, that would be great. And I do think, as Robin said, I do think our governments need to take a lead. And if it has to go on funding, it has to go on funding. I don't know any other kind of organization or job that I've had where my performance wasn't based on the amount of pay that I got. And even to add to that, who is the ones that are auditing and giving performance appraisals on our healthcare providers? You know, we can do proms and we can do prems and whatever like that, but what's happening with that and how we're going to make change? And those are the kind of things I can say as a patient that you might not be able to say. But anyway, those are the ways.
Absolutely wonderful to hear that, and to hear the strength. Robin, go to you, and then I think Carrie has her final bullet round.
Yeah, thanks. Oh, yeah, no, agree with everything that's been said, and I do agree with Sandra that money does talk in many ways, and certainly what we've seen in the UK is the big health and social care research funders now have an expectation that actually people who would benefit from research will be involved in the design, the delivery, the dissemination. And that has made a huge step change in terms of people's engagement with people's lived experience of health and social care, because those who want to do it feel as a mandate to do it. Those who are perhaps a bit more reluctant, a bit shy about it, realize they have to do it. And if they don't do it, they won't get funding. And we're far from perfect. But you can see over the last 5 years that the engagement of people with lived experience throughout the kind of research process, and indeed being involved as co-researchers, has stepped up hugely. The other thing I think we need to think about is giving people the skills and the confidence to meaningfully involve people in their practice and their research. And I think there's a big role for professional bodies, regulators, to make sure that throughout people's professional career, right from the time they're qualifying, through post-qualifying, in terms of their performance appraisal and development, that we have the skills and the knowledge of how to engage people and communities in their work is absolutely seen as a key health and social care professional task. It shouldn't be a nice to have. It should be something that we should see as a requirement of strong professional practice. And I think if we embed it throughout careers, then as we get the young professionals qualifying and going on, they'll just see it as part of what they do. And that's really where we're going to change the culture of our systems to make them much more community orientated.
Mm-hmm. Thank you, Robin. And what I'm hearing about is we need accountability in our system. How we hold providers accountable, how we hold ourselves accountable, and really build it into the fabric of how we do healthcare. It should be an automatic that we engage with communities, patients, and families, not a nice to have, but a must have. And I think probably aside from this audience, many might think it's still a nice to have and not an absolute must. And so there's some work to do to kind of embed that in our system. And I wondered now if we do go to what Walter was saying, a bit of a bullet round. So any final takeaway nuggets, words of wisdom that you want people to walk away with, maybe something you generated through the discussion or something you want to go back to that you mentioned earlier. And I'm looking at the top of my screen, Helen, not to put you on the spot. Do you want to go first and then over to Nakia?
Sure. Thank you for that. Well, I think we talked about it kind of throughout this discussion, but I think what we're hearing is that support and changes are needed at that individual level, that interaction and that includes the caregivers within that, but also the community level, those support systems, and at that system level. And it's changes all the way through there that have to be worked at all at the same time, but it's very much possible.
Thank you, Helen. Nakia.
So these kind of bullet speed rounds reminds me of a quote from an event I went to by ex-MP Selena Cesar Chavanes, and she said, "Equality is ubiquitous, equity is not." So if we are going to really have conversations about making, our healthcare system a more equitable, inclusive, and diverse space, we really need to have conversations about how are we defining the very things we're trying to change.
Thank you, Nakia. I'm going to take that one away. Robin.
Yeah, not quite as snappy as Nakia's, but I think there's something I'm being really clear about the fact that there's different ways that people's lived experience can shape and get involved in health and social care systems. And whether you're going to get somebody or somebody's going to be involved in terms of improving a pathway, or perhaps designing a population level approach, or perhaps being a kind of constructive challenge to what's currently in place. We need to be clear these are different types of roles, and therefore we'll need different types of supports and skills in order to do them. So I think we need to go beyond simply saying it's important that people are involved to saying, well, how are they involved? How could we strengthen their involvement, and how we can support them to do that in the long term?
Thank you. So really digging into the how. Thank you, Robin. Sandra.
So I wanted to take this moment to thank IFIC Canada for the job that they're doing, and all the co-panels, people that are here, and everyone that's online, healthcare providers and patients and families, because I realize that you're all dedicated to making this happen. And although we brought up things that are not working and we're addressing areas, there's a lot of things that are working. And the people here that are on this call are dedicated, and they work really hard at trying to make the system better. And I want to acknowledge that these things that we're bringing up today are ways that we can work forward. But, our healthcare, I get excellent healthcare and ways. There's things that we can always improve. But I want to acknowledge to everyone this year, our primary care providers and those that are working in healthcare, and just want to say thank you. Thank you for everything that you do.
What a beautiful way to cap off this discussion. Thank you so much, Sandra. And thank you to everyone for engaging in this discussion and creating the space where we can really learn together. And in the spirit of learning, we also wondered if we were to continue this conversation around engagement in particular, in the spirit of integrated care, are there particular topics that you're most interested in? And the reason why you see the topics in front of you is we have developed webinars in these specific areas. And actually, Sandra was a key member among many other patient and caregiver partners across Ontario in co-developing and co-delivering all of these different sessions. And so you have communication, compassion, and empathy, bearing witness to lived experience, equity, diversity, and inclusion, navigating difficult conversations, preparing for engagement, conducting engagement activities, as well as evaluating engagement activities. You might find all of these important and interesting, but rank what you find most important to maybe what you're least interested in, just so we could prioritize for future sessions. In addition to, you might have other topic ideas that you can put into the chat as well. And Trisha and Yinka, I'll leave it to you to close the poll whenever you feel like you have a lot of responses.
And let this go a little bit because it's a complicated poll.
Yeah, there's a lot to absorb in this list. Yeah.
But we might take the time to talk a little bit for a moment about some of the upcoming work as it relates to integrated care. And I saw very early on, so I'm very appreciative of the last time we brought the entire country of community together at the North American Conference for Integrated Care in 2021. And this is one of the ways to bring together through the webinar, but I think really bringing everybody together across the entire country is a great opportunity and importance. And we will bring the next webinar like this in February. We're doing these every quarter, and we might start doing them a little bit more frequently. We have some content coming up. I want to appreciate everybody joining today as well. And Jodie, maybe I'll turn it over to you if you wanted to highlight anything about our future together.
Thank you. First, just a reflective piece for all of us and for the 135 people that are still online with us. We are at an inflection point in health and care, and the dominant culture of the past, which was designed around organizations and providers, is shifting. It is shifting. We are in the ambiguous innovation phase where what we have done in the past no longer works for us today. And we are seeing it in the lack of health creation and not reaching population health and well-being goals. And the answer is shifting power to community and people to understand what is most important and how does that become the DNA of everything we do in health and care. And so we are part of, together, a movement for change to get to the possible future. Very hopeful around where that'll go. And IFIC Canada is committed to playing a central role in elevating this possibility and having it impact every single part of Canada, North American, and broader in partnership with all of you. In that light, we will be bringing the next conference to Canada in Calgary the first week of October. It'll be October 2nd, 3rd, and 4th with a focus on community and co-design as a central component, as is everything we do at IFIC Canada. So take a look at the poll results around where you're most interested in learning. That'll help inform next steps for IFIC Canada and for the work that Carrie leads on behalf of IFIC Canada, Walter and I, although Dr. Carrie Koletsky is part of our leadership team at IFIC Canada, a special thank you for facilitating this. You did a wonderful, seamless job despite the technology. To Helen, Robin, Sandra, Nakia, what a great fortune for us having you join us and bring this to life. Carrie has a learning series, and we will be following up with the curated material from today, along with all these links and the incredible resources that everybody put into the chat. We will bring that back out to all of you. Just a quick, we have two pieces before we close with 1 minute left. If you could just share, to what extent was today helpful to you in your knowledge about the topic we were covering today? To Yinka and Trish, who are doing the polls, thank you for being so seamless and adaptive as we move. We'll close this poll in a second, and before everybody leaves and signs off with the energy that you have and all that you have shared, and this is a true collective experience. How incredible that we can have a live chat and resources shared while we're in shared purpose with the topic. Please share one word that describes your experience in being with us today as you log off. One word. We consider this our snowball, but it gives us just a litmus test around how did you experience this session today? Inspiring, informative, engaging, enthused, hopeful, useful, motivated, re-energizing. Yay. There is hope. We are holding this space in transition for the future. IFIC Canada is in service of that. You can reach us anytime. Wishing everyone nothing but health and safety and goodness. And we look forward to coming back together in shared purpose again. So inspiring watching the words come in from all over the world.